Hi, I'd like to welcome you to our program on addictions. Today we're going to be talking about stages of change and a trans-theoretical model of treatment of addictions. Judy, what contributions has this approach made to the field of addictions?
It's become more important every day as more people have realized that what we used to do, I think, sometimes in addictions inadvertently was we would have a particular kind of approach, and if the client didn't fit, if the client wasn't in the right place for that, then we would have to wait. With this trans-theoretical approach, which, since it's trans-theoretical, we know that that means that people from a lot of different theoretical perspectives are interested in it. With this, we take the client from where he or she is and fit the strategies we use to that.
I especially like that because we almost assume that people are ready to change just by the virtue of the fact that they come to see us, or the ones who maybe are forced to come or mandated don't want to change. And this gives us a continuum for how to look at the change process.
Yeah, for a long time we had nothing to offer somebody who didn't want to change except trying to force them into what we were ready to give them.
Yeah. Why don't we bring out our guest, John Norcross, and learn some more about this approach. John, welcome.
Thank you. Judy?
John, could we start out with having you maybe just give us a little bit of an overview of the work that you've been doing recently in this area?
Certainly. For the last 20 years or so, we've been researching and applying this trans-theoretical model. Simply that people present, as you've already said, to therapy and in their own lives in different, what we call stages of change. Everyone comes to a different place. The pre-contemplators don't acknowledge their problems. Historically, they've been called people in denial, but we try to avoid that term. It's pejorative, and hardly anyone likes it if someone comes up to you and says you're in denial.
So that's the first stage, is pre-contemplation?
Pre-contemplation. Now, most people historically would have called it denial. Then, over time, and with some assistance, therapy or on their own, people move into contemplation. I have a problem, I acknowledge it, but I'm not ready to change yet. In fact, most of the people who present for treatment are, in fact, in contemplation. They know the problem, they like to change it, they're not quite sure how to get there, or not confident. Over time, they begin making small baby steps into the third stage, which is preparation, made famous by that movie, What About Bob? In which a patient, baby steps, baby steps. You're not ready to jump full-fledged into action, so instead you make these little movements and go back very tentatively and anxiously. Over time, with some success and additional commitment, people really fly into action, which most people equate with the entire change process. But as you can see, it's much broader than that. And as you said earlier, most of us would like all our patients in action. They're easier to treat, the outcomes are much better, and that's historically where we are. Once through action, though, we know it's the next stage is maintenance. If you look at the literature, we should all be embarrassed to assume that once people changed in the past, they remain changed. We now know the relapse rates, or as we prefer to call it, the recycling rates of addictions is at least 2/3 for a year. 2/3 of patients are going to relapse, or at least slip. So maintenance is a terribly important stage that has been historically neglected. So in this process of change, pre-contemplation, contemplation, preparation, action, maintenance, and then depending upon the person and the problem, maybe even termination out of the problem cycle.
So then are the techniques that you use or the strategies you use matched to those particular stages?
Exactly right. We call that stage matching. Both treatment strategies and relationship stances differ depending where the patient is.
Can you give an example?
Sure. Well, for example, the patient that I interviewed, LC, he presents in the maintenance stage with regard to his cocaine abuse. He has been abstinent for over a year, and he's working on to prevent relapse. So my relationship style with him is much more as a coach, an experienced consultant saying, let's look at your relapse prevention plan. How are we going to avoid slips? On the other hand, he is only in preparation with regard to his alcohol abuse. He knows it's a problem. He's tried to cut down a little, but and you can see it, he's a little anxious. At that point, I'm much more of a let's call it a Socratic teacher, where awareness, small baby steps, helping him develop a plan. And even for other, like most people, he presents with a multitude of problems related to his addiction. He's also in contemplation with regard to what he wants to do with his life, his job, his relationships. So there we are much more in the way of a nurturing parent, helping him understand his goals. So the treatment strategies and my relationship stance just move along with the patient.
So even with one client, you may use different strategies depending on the particular issue that you're talking with him or her about at that moment.
Exactly.
And where in the stages of change he or she is right then.
Yes. Intuitive, experienced therapists do that automatically. In the trans-theoretical model, we hope to be just a little more explicit. And after a while, we actually educate the patient about the stages so they can realize there's tremendous transfer generalization from solving one problem to a next.
How does your approach conceptualize addictions then?
Flexibly and commensurate with the client's perspective. Much like the stages of change following the patient, we think the conceptualization of addictions should be tailored to the patient. So if he or she prefers to think of it as a medical model, we're fine with that. A behavioral disorder. Our model is a model of change, not psychopathology. And we should all be very wary of imposing a model of behavioral disorders onto a patient. For us, that's like the Procrustean bed. You know, you stretch or shorten the patient to fit your conceptual bed. We'd rather move with the patient, both in terms of treatment and how he or she can most profit
toward whatever outcome the client was interested in?
Yes. Well, that's a co-creation, to be sure.
Good.
But as a patient enters contemplation and action, aware of their problem, emotionally centered, and then behaviorally working toward it, almost always there's very good agreement about the goals. So outcomes will be individualized, probably a little more than other therapists. I tend to be ambitious about outcomes. I'm looking at both behavior change and sometimes personality change. But that's a patient's right to decide what they want to do, short of, you know, of course, our ethical responsibility if they're hurting others by their choices.
Just in terms of the strategies, could we go over for just a minute? I know you don't have time to go into great detail about this, but each of the stages, if a person is in pre-contemplation, for instance, and what you said, I think, is that most people coming in are at least aware at some level that there's a problem.
Yes.
But you might be working with somebody in pre-contemplation. So what would you be focusing on then?
Yes. Well, my colleagues, Dr. Jim Prochaska and Carlo Di Clemente, who developed this model, have what they call the 40-40-20 rule. That is, in the population at large, 40% of the people with any behavioral problem are in pre-contemplation, 40% are in contemplation, and only 20% ready for action. So if you develop a treatment strategy all about action, you're going to be very disappointed. And in fact, in addictions we have. Very frustrating, not only for clinicians, but very ineffective for clients. So unfortunately, we know least about how to help a pre-contemplator, just because we haven't done lots of research on that. And yet there are ways we know work better than others. And as we like to say, the stages provide both proscriptive, what not to do, and prescriptive. For example, pushing a pre-contemplator to say, go to abstinence immediately, is just a huge mismatch. It's unempathic. You're just missing each other terribly. So instead, we would ask them to move into contemplation by saying, let's collect data about this. If it's not a problem for you, are you willing to work with us? How can we become more cognitively, and probably more importantly, emotionally invested in the problem? So the first important step is to move people stage by stage. Our natural industriousness as therapists want them to move from pre-contemplation to maintenance overnight. That backfires. And we have lots of research that shows that's when people start dropping out. They feel unappreciated, unheard, a terrible mismatch.
Yeah, it used to be with treatment, there was an assumption almost that all of the clients were in pre-contemplation, and then what we would actually do with them was the opposite of what you need to do with somebody in pre-contemplation. We would try to push them into action.
Yes.
Then if somebody's in contemplation or preparing for action, you would do more coaching with them.
Yes, and at that point, you start doing self-reevaluation. What is it that this person wants in terms of their goals and priorities? Again, because it's a cross-theory or integrative model, people can bring their favorite techniques to that, whether it's a pros and cons assessment, whether it's two-chair gestalt work, whether it's just saying, what are your priorities, which we do in the videotape with LC. And then the commitment-enhancing techniques to help them just gradually move on through in the commitment. And in fact, as you can see, pre-contemplation and contemplation are where the so-called awareness and experiential techniques are really the most effective. Once you get into the action and maintenance, that's where the cognitive and behavioral techniques work. So while most people see this as some sort of antagonistic fight, you know, awareness versus behavior change, for us, it's very complementary if you just think people need different things at different times.
Yeah.
What happens when you have someone come in with not just an addiction problem, but also a mental illness, what we call dual diagnosis?
And of course, we know what a high prevalence that is. Well, our motto is we treat people, not disorders. So there's no incompatibility in that at all. As with LC, with most patients, I rarely see people with one specified disorder. We're all just grappling along with life the best we can, which means there's always other concerns, whether they reach a diagnostic severity, severity to get a diagnostic entity or not. So the process is virtually the same.
So you're focusing on what this client at this time is ready to think about changing.
And even perhaps pre-contemplation. We purposely start with a maintenance behavior to reaffirm the patient's progress, to remind them of their strengths and resources and how well they can do. Then we work back in the stages throughout a session in order to get more active. So maintenance typically takes a brief period of time. It's a quick checkup almost. You're problem solving, you're trying to prevent the relapse. Then you move into action, and then you move back. And sure enough, as the relationship develops, people who are once in pre-contemplation begin to almost naturally feel accepted, particularly when you can say, if you say you have a problem, that doesn't mean you have to change it tomorrow.
But you do emphasize, don't you, the degree of success that the person has had in maybe maintaining some other positive changes other than the one that you're focusing on.
Yes.
Then.
I think most experienced therapists have learned to mobilize the patient's resources and to emphasize their strengths. We do it a little more because we realize that 99% of the client's waking life is outside the consulting room. So if one can point that out and mobilize those natural resources, that carries them through.
You mentioned you and your colleagues, and is there research that supports this model?
There's extensive empirical work over the last 20 years, spearheaded primarily by Jim Prochaska up at University of Rhode Island, my mentor and collaborator, and also Carlo Di Clemente, now at University of Maryland. It's hard to summarize 20 years of research and $40 million of federal research grants in a few moments. But let me just say, it's been done with 16 problem behaviors, starting with smoking, alcohol, cocaine abuse, heroin, moving into weight, depression, anxiety disorders, sunscreen. We've also done some interesting little turns. For example,